So the COVID-19 pandemic is now, well over a year old. Scenes like this have become very common. There are many different dimensions to discuss regarding the pandemic, but a major one that's been, part of the public conversation from the very beginning has been testing, the importance of testing, availability of tests, different countries' approaches to testing. There's reasons for this. Probably the biggest one is the importance of pre-symptomatic or asymptomatic transmission in spreading COVID, and the fact that there's just really no way to bring to transmission under control without widespread testing. So in this paper, what we wanted to do was take a look at testing for COVID as a sort of case study in how to handle testing during public health emergencies like this through the lens of an idea Ashely has been developing for several years now, and it will be a chapter and an important part of her forthcoming book. The idea is diagnostic justice. So this is what we're going to do today. Ashely will talk for a little bit about COVID testing, a sort of primer on COVID testing. We're going to talk a little bit about some of the ethical issues involved with diagnostic testing in public health surveillance, introduce the idea of diagnostic justice. And then we're going to argue that the way testing has been handled during the COVID pandemic raises two, we'll just call them outstanding difficulties or unresolved ethical issues about testing during something like this that has to do with meeting demands of diagnostic justice, and we'll conclude very briefly with some implications for global health policy.
So very briefly, many of you probably know this already, there are three main types of testing for COVID-19. The first two that are on the slide here are both used to detect active infection. So that's PCR testing and antigen testing. These are done usually in the first and foremost instance on patients who need some kind of clinical care. There are other reasons for it as well. We'll get to that. PCR testing, actually, some of you might look at this number, 70%, and say it's more accurate than that. It is, but when you take into account the person taking the sample, the 99% goes down to 70, so it's around 70% accurate in actual use. Antigen testing has the advantage of a quicker turnaround time for results. So it's used in point of care, but it's not as accurate as PCR. And then there's antibody testing, which is in general, as you probably know, not done for the purposes of diagnosing an active infection, but rather to figure out who has had the virus previously. I didn't put any numbers here. People are still debating about that. But for our purposes, it's just enough to know that there are many different ways to test for COVID, and those are used in some instances in clinical care and other instances in public health surveillance.
So just very briefly, when we're talking about testing during the pandemic, what we're worried about here is testing as part of public health surveillance. Diagnostic testing for COVID-19 is used for public health surveillance. There's two types of this: passive and active screening. Passive screening, mostly I'm not going to worry about these too much, but for the most part, what the major discussion has been about is it's called active screening, that is using testing and test data, gathering testing from data in mitigation for the pandemic. I mean, some passive screening is being done. Obviously, national health agencies, the WHO, et cetera, are curious about tracking large-scale patterns, collecting, data for further research. But testing has largely been used as active screening with the main goal of mitigation, of cutting down, controlling transmission, and so bringing caseloads under control. So there's a number of issues that are involved with ethical issues, that are involved with diagnostic testing for active screening. Just to give a couple here, and there's a serious question about whether people can refuse testing in a situation where there's a public health emergency and active screening is being done. I mean, in medical context generally, patient autonomy being as important as it is, refusal of diagnostic testing is a kind of almost let's say a baseline assumption. So in clinical settings, for example, people, of course, have the right to refuse a test. But given the negative externalities on others of refusing testing in a public health emergency when active screening is being done, there's significant questions about whether or not autonomy can be abrogated in this case and whether or not people can be allowed to refuse testing. It's similar to, analogous to, in certain ways, debates about vaccine mandates. So, I mean, a perennial question in any medical, for medical ethics period, how far does patient autonomy go? It extends into this realm as well. Does this extend far enough that people can refuse testing during a public health emergency when active screening is being done? Testing has been handled in different ways in different countries. In China, for example, testing was frequently mandatory. Chinese government would throughout the pandemic often order entire municipalities to submit to testing. In our country, the United States, Ashely, in my country, I mean, it's been totally voluntary. There's been a great deal of encouragement to get tested, but of course, unless you're crossing a border or traveling, there's been no mandate, legal requirement, or anything like that to test. There's also significant questions here about how, in any situation, data is used. Exactly what data is being decisions data is being used to do, what kinds of thresholds are set for different sorts of transmission rates to make different kinds of decisions. I'm going to talk about that in a little bit when we cover our two outstanding issues, but that's just, briefly an overview of some of the issues involved with active screening and during public health surveillance.
Mm-hmm. So the idea or the concept that we bring to bear in this paper on the ethical issues that arise with diagnostic testing, especially in the context of a public health emergency or a pandemic, is something that I call diagnostic justice. So if you are at all even a little bit familiar with bioethics literature, you've definitely read about treatment justice. I don't know if they actually call it treatment justice, but questions like organ allocation, for example, very commonly discussed. In my forthcoming book, it'll be in print in July, so soon, I talk about diagnostic justice in terms of when diagnostic tests are a scarce resource, but we take that concept and extend it here. So next slide, please. And what we want to say, or what we use this term to denote, is that the idea that the burdens and benefits of diagnostic testing have to be distributed equitably, and diagnostic resources must be allocated fairly. So there's an issue of allocation and also an issue of burdens and benefits of testing. The next slide. And what counts as just or unjust depends on context. And we've identified three contexts, and there may be more, but there are at least three that are important when you're thinking about diagnosis, diagnostic testing, who to test, when to test, is it just or unjust to test? So these three contexts are clinical care, clinical research, and public health. So clinical care is, you think of a person going into the doctor, they're symptomatic, they're tested because their results would make a difference to their care. This certainly happens with COVID. This happens with many other conditions as well. So why do you test the person? You test, or who do you test? Someone who has symptoms. And why do you test? Because the test would presumably make some sort of difference to their clinical care. When it comes to research studies, clinical research, the reasons for testing are different. It's not for the clinical care of individual people or participants or patients. Rather, it's for inclusion criteria for the study. So you test people that you want to include in the study, and when you don't know if the results would make a difference to whatever it is that you're testing. And so some of you might recognize this as Miller, Frieden, Broden principle of equipoise. And then there's the public health context. Who do we want to test? It's different than in the clinical care and the clinical research context. We don't just want to test symptomatic people. We don't want to just test people that we're going to rule into or rule out of a study, but we want to test as widely as possible. And why? Not to treat the individual people, but to mitigate / contain the disease, at least in the context of a pandemic such as COVID-19. So the reasons for testing and who you test or not are going to depend on whether you're in the clinical setting, a research setting, or a public health setting.
Okay, so I'll argue here briefly for what we think are two outstanding worries about COVID testing and diagnostic justice, both of which we think are instructive for future public health emergencies. First, in countries where there is, or in any situation in which there is no mandate for testing, which testing has been voluntary, there's at least a chance of something like, we're going to call it a diagnostic misconception operating. There's a famous problem in clinical research ethics, the therapeutic misconception. Therapy and clinical care are supposed to be kept very strictly separate. This is a principle of research ethics codified in the Belmont reports, other documents and codes. But of course, in practice, keeping that line in place is difficult. Research subjects often don't understand the difference. They think that they may be signing up for just some kind of extra special clinical care when they volunteer for a clinical trial. That's called the therapeutic misconception, and it raises significant questions about whether or not they really have given fully informed consent, among other things. Something similar may be operating here. People may be submitting to testing as part of active surveillance regimes, thinking that this is part of their clinical care in some way, thinking that this is essentially like a first step in treatment, and so not totally understand exactly how their data, the test data that it's gathered from their test, is being used, what exactly its purposes are, and how it may or may not impact them. There's plenty of evidence, the sites are in the paper, we can talk about it later, that people actually have made this mistake. So for example, a study in England of contact tracing apps showed that most of the participants would not use the app in the study. Most of the participants didn't want to use the app because they just totally didn't understand how the contact tracing data that their phone would gather would be used, how it would hurt them. There's an awful lot of misconception involved in this area. This raises some concerns because, as in the therapeutic misconception case, there may not be fully informed consent to people who are volunteering for testing, but that is less of an issue, we think, in this case. The biggest issue here is simply that it raises sort of worries about nudging people to volunteer for tests as being a superior alternative to just mandating tests during active surveillance. If you're actively surveilling a population as part of mitigation and you're relying on volunteering for testing to get the data that you need, but people are volunteering under sort of false pretenses, they're assuming this is something that it's not, then it doesn't really, it seems that there's some sort of, it doesn't really seem that volunteering for testing has a strict moral advantage over just compelling testing in some way, and it raises sort of similar ethical worries in the therapeutic misconception case. The big one here is there are real worries about the way in which data gathered from testing is used and the way in which the burden or which mitigation decisions differentially impact communities, as has been well documented at this point in time. One of the biggest tools used to fight COVID, lockdowns, has very unequal distribution of burdens. Some communities are disproportionately burdened by things like school closures, stay-at-home orders. Other communities, everybody is burdened a little bit, but other communities have less of an issue with them. When data gathered from COVID testing is used to inform decisions about when lockdowns go into place, then there is a situation we have where people are volunteering or being required to submit to testing, and the data is being used to make public health decisions that hurt some more than others. So if you have a community in which school closures, for example, which, let's say, access to public schooling is tied to free school lunches or nutrition programs or something like that, which is very common in different parts of the United States. Individuals submit to testing without really understanding what's going on, thinking this is part of their clinical care. They're just trying to get some information to tell their doctor or something. The data is then used to inform whether a school closure should go into effect. And that, for people who are dependent on things like supplemental nutrition programs through a public school, greatly impacts some families, and for other families, it doesn't. And you have a distributive worry here about the way in which data is being, way in which burdens of something like a lockdown or a school closure is being distributed, and the way in which people's data from their submitting to testing is being used to inform those decisions. Data from COVID testing, from active surveillance, has been used in a variety of ways to do things like inform decisions about lockdowns. So famously, New York City has a very strict threshold of a 4% positivity rate. Every time the percentage of positive tests rose above 4%, the school was supposed to keep schools closed. Once it fell below that, they reopened public schools. School closures in New York City have been much discussed in the United States. They've had very unequal burdens on different families inside the metropolitan area. So there's clearly a distributive worry here. The way in which data is used can exacerbate existing unjust inequalities by placing undue burdens on some communities as opposed to another. And this raises some, let's just call it an outstanding worry again, about COVID testing and diagnostic justice.
So a few implications that we draw out. First is that it's actually, we think, not possible to completely separate clinical care from public health when it comes to questions of when to test, who to test, why to test, and so on. While it is easier to understand why to test, when to test, and who to test in the clinical setting, perhaps because it sort of maps on to who to treat or not to treat, perhaps for other reasons. And it is a bit more difficult to figure out who to test, how to test, when to test in terms of public health. These two are intertwined, and that's okay. There doesn't have to be a perfect separation. But what this means is we think that testers, people that are testing, have obligations to those who they are testing, right? So the testers and the tested have this relationship in the clinic. Again, it's easier. The physician is going to test the patient when the patient has symptoms and the physician wants to help the patient get better. And that seems, a pretty clear benefit for the patient. They submit to testing because they are hoping for treatment and they want to get better. So that doesn't seem, in most cases, to be any sort of injustice or exploitation, et cetera. But as Bryan said, in the public health setting, testing isn't quite so neat and clean, ethically speaking. So someone might submit to testing and they might have benefit, they might have no benefit, and they might have negative benefit, right? So that's usually not the case in clinical care. And then in between, I haven't seen anything yet about the research setting. That's sort of this in-between domain. And we do have, as Bryan said, we do have some literature to draw on with the therapeutic misconception. So we do think that there are obligations there as well. But in particular, not only are there obligations in the public health setting when it comes to diagnostic testing, there hasn't been a lot of talk about it. Why is that? Well, we are in the midst of a global pandemic. It is an emergency, and you've probably all heard the term emergency ethics, which means something like, we'll think about the ethics later. But we think it's really important to think about these things now. So we think that there are obligations. We need to think through them. We hope to bring to bear this lens of diagnostic justice in order to think through them. We haven't, by the way, solved all the issues, but we think that it's an important project, to understand A, what is going on right now, and B, what we can do moving forward to be more just in distributing burdens and benefits of diagnostic testing. Next slide. So just a brief conclusion. Again, we think that when you think about diagnosis and justice, put them together, diagnostic justice, then we see that there are moral demands on testing policy. And so then we need to think about that policy. We need to develop protocols that in fact are just rather than unjust. And it's not okay just to say test, 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 and no one will ever be harmed, because that actually isn't the case. And the best case is the people who are tested and the communities in which they reside are benefited. Second best would be if it's at least neutral. And of course, we want to avoid situations in which people are signing up to be tested, and that somehow in turn hurts them or the community of which they are a part.